Today's topic is we are going to discuss the various causes for unilateral optic disc edema. All right. So, what is disc edema as such? It is a clinical presentation of various life or sight-threatening conditions. The causes can be multiple. It can be because of pathology in the eye per se, or there can be any pathology in the brain or intracranial lesions, or it can be a manifestation of systemic diseases. Okay. So first, so you all know there is true and pseudo disc edema, right? Okay, Rutuja, you are there. Is Rutuja? Yeah, Rutuja. So, can you describe these two fundus photograph?
The picture on the left is a disc photograph of the left eye, which shows blurred disc.
Fine to the disc alone, since
Okay.
your disc edema.
The disc margins are blurred. We cannot make out the cup disc ratio. The vasculature is that we see at the margins. The picture on the right is a disc picture which shows clear-cut disc margins and
Okay. Why is it important for you all to know or to differentiate what is true and what is pseudo? Why is it important?
For judging the treatment.
Correct. It's going to help you to come to a diagnosis and accordingly taper your investigations and management. Okay. So in true disc edema, symptoms. Patient is going to be symptomatic. He's going to complain of defective vision or field of vision, other issues which come along with that. In pseudo disc edema, usually the patient is asymptomatic. He usually walks in for a regular eye examination. The disc elevation, okay, that is the RNFL elevation along the disc. It extends beyond the disc margin in case of true disc edema, but not so in pseudo. It is confined to the disc. Okay. In pseudo disc edema, here if you'll see the margins are defined, but they're bumpy margins. This is a patient with disc drusense. Okay. Next is cup. The obliteration of cup is one feature which is common to both pseudo as well as true disc edema. Okay, the cup will obliterate in both the conditions. Superior venous pulsations are usually definitely will be absent in true disc edema. In pseudo cases, they will be present, but normally 20% patients can also have the absence of this venous pulsations. Okay, but otherwise, if a patient will drusen, first time when you see them, they have pulsations, but second time when you on a follow-up, if you see it is absent, that means there is some disc edema, a true component also is present. Vessels over the disc. You need to see whether there is well defined, they're seen clearly. In true disc edema, the vessels are obscured, okay, because of the associated edema. But you see in this optic nerve drusense, you can see the margins, the vessels running clearly, okay. Then coming to peripapillary changes, such as hemorrhages and hard exudates, they're usually seen with two cases, but not so with pseudo disc edema, okay. Then on fundus fluorescent angiography, what you'll expect in two cases?
there'll be leakage on the disc that we'll see in the cases of true disc edema.
Okay. In case of pseudo disc edema, in case of drusense, what you'll see?
Staining.
Staining or there'll be autofluorescence. Okay. Fine. These are a few other examples of pseudo disc edema. One is hyperplastic disc. Basically, hyperplastic disc means the diameter is much smaller when compared to the normal optic disc. What is the average diameter of a normal optic disc? How would you describe a normal optic disc? Okay, how would you describe that? What are the features of an optic disc?
Vertically oval, ma'am,
Okay,
with the regular borders, margin,
regular borders,
regular margin, ma'am.
margin, okay. See, basically optic disc, you're going to see the size, okay, the neuroretinal rim and the cup, plus the orientation of the vessels. All right. The vessels are normally oriented nasally or temporally. This is a tilted disc, okay. This is usually seen in patients with myopia. Here only there's elevation of the nasal margins. But as you see, the vessels are clearly well made out. Okay. So the few examples for disc edema are drusense, hyperplastic disc, and tilted disc. All right. Next, how do you assess a patient with unilateral disc edema? The most important thing is history taking. Listen to the patient. He gives, as it tells us history, you will come to know what he is having to a major extent. Okay. Other thing is clinical examination, which includes optic nerve function test. I've listed out here. They are the visual acuity, color vision, pupillary assessment. So what are you going to see for in the pupillary examination? In unilateral cases, what will be present? RAPD. Okay. If it is bilateral, If it is severe in one eye, RAPD is going to be there. Okay. Then assessment of extraocular muscles. Why is it important to assess the extraocular muscles in a patient with disc edema?
Raised IOP can also raised intracranial tension can also affect other cranial nerves like sixth cranial nerve.
Okay, one is papillary edema, which can be associated with an ophthalmoplegia. Other conditions, can you tell?
Orbital apex syndrome, cavernous sinus syndrome.
Will they present with unilateral disc edema? We are talking here in reference to disc
unilateral.
edema.
Okay.
Okay, anyways, so you need to know
Other
that.
MS and all which present with papillitis can and also have cranial nerve involvement.
Is it? Is it frequently? Is it very frequent to have both an ophthalmoplegia and optic neuritis in MS? There are much more frequent
No, ma'am.
causes or common causes we'll see across. And fundus examination. I cannot emphasize more on this. You'll need to see the disc, how it appears. Okay. So other test, what you're going to do is perimetry field test. You all know, it will tell you all to what extent the visual field defect is present. VEP is important. MRI or CT based on your clinical assessment, OCT, ultrasound, and blood investigations on basically what you suspect in the particular patient. So these are various causes. I'm going to describe with the help of cases. Okay. So first, there's 56 male. He's a diabetic. He has sudden painless loss of vision in the right eye since 5 days. In the right eye, vision is defective. He has RAPD. Color vision is defective. Left eye findings are normal. This is his right eye fundus. Can you describe this disc?
The media is clear. The size of the disc is moderate. The vessels seemed obscured while leaving the disc. There's almost a cupless disc with blurred margins and elevated borders. Uh, we can also see a few hemorrhages, disc hemorrhages around. So it is suggestive of a true disc hemorrhage or true disc edema.
Okay. Now this is the other eye. How is this disc?
It's a as we call it is a it can be a disc at risk because it is
Can be.
means it is a disc at risk because it's almost a crowded cupless disc.
The small
Small,
crowded
yeah.
disc. Okay. So now this patient has an inferior altitude defect in the right eye. So what is the diagnosis now? He's a diabetic, presents sudden painless loss of vision, he has inferior altitude defect with a disc edema. So what do you suspect him to have?
Non-arteritic ischemic optic neuropathy.
Correct. So this is NAION. What are the other causes, normal causes for NAION, Vignesh? Or once you can answer.
Ma'am, other risk factors for NAION will be anemia. Smoking is
Apart from diabetes, this patient is diabetic. So
Yes,
what are
ma'am.
other causes? Other common causes?
ma'am, hypertension, smoking, dyslipidemia can precipitate. Hyperhomocystinemia will predispose to accelerated atherosclerosis, which can in turn cause NAION.
The rare causes are anemia and OSA, that is
Yes,
sleep
ma'am.
apnea. Okay. Fine. We move on to the next case. He was 59 male. He came for regular examination. Okay. He had no symptoms. But then he's again a diabetic with dyslipidemia. And he had history of poor vision in the right eye since childhood. He was diagnosed to have right eye anisometropic amblyopia. So if you see vision is definitely less in the right eye, the left it was okay. There was no RAPD in either eye. The left eye, the color vision was good. Other aspects are normal. So this is the fundus photograph of the right eye. You can see the small disc, but the media is hazy because of cataract. Now this is the appearance of the left optic disc. Okay, Saurabh is not here. Pranab, can you describe this disc?
Ma'am, on the right eye media is hazy.
Leave that. Come to the left eye alone.
Okay. Ma'am, in the left eye, the media is hazy. The borders of the optic disc are not made out. On the temporal aspect of the disc, we can see one area of hemorrhage. Superiorly, also, we see an area of hemorrhage. Along with that, we are able to see some peripapillary changes, and also the vessels are discolored like a lipemia picture in patients who have dyslipidemia.
Okay, basically there is some more disc edema, some more pallor too, and streak hemorrhages, right? Okay, but vision is intact, color vision is good, there is no RAPD. Now see the HVF of this patient. He has few paracentral depressed points. In the setting of no visual complaints, patient walks on this disc with history of diabetic and dyslipidemia. What are you going to suspect? What do you think he's having? What is the reason for disc edema in the left eye?
Diabetic papillopathy.
Okay, good. Next possible condition?
NAIR, ma'am.
No, NAI is going to be symptomatic. Incipient NAI. Okay?
Pending.
Yeah. So this patient had diabetic papillopathy. So in these conditions, you need to observe the patient very closely. Okay, a diabetic papillopathy usually resolves within 3 to 4 weeks. Okay, next there is a 61-year-old female. She presented with sudden and painful loss of vision in the right eye since a week. You see the left eye findings are normal. Right eye vision is peripr. RAPD is present. Her extraocular muscles movements were painful. Okay, this again shows a disc edema. It looks similar to an ischemic optic neuropathy. Some amount of pallor is there, streak hemorrhages. Okay, can this be NION? Why?
It's painful diminution of vision. So
Is it only painful? Any other reason? Can you say it is not ischemic?
disc is pale, pallor, and
Ischemic?
hyperemic disc edema, which
No.
is seen.
Divyansh?
And the vision is extremely.
See, no PL never ever happens in an ischemic pathology.
Yes.
Okay, that's what you need to remember. Right? It at least be PL be present, but no PL never in ischemic optic neuropathy until unless it's GCA. Okay?
Ma'am, is there any difference of presentation of the edema per se in GCA and like in this disc and NAION, or the edema can look similar in both?
Yes, that's where your history comes into play. A sudden, painful loss of vision, such a dramatic vision drop, you should think of atypical causes or optic neuritis.
Ma'am, the edema on like what we observe.
Hmm.
So
See, it
can we
can-
comment on that? Like, can we comment on looking at the edema? Can we comment whether it is because of an arthritic cause or a non-arthritic cause?
See, arthritic causes, the ischemia is more severe. Okay, if you remember in giant cell arthritis, it is described as chalky white disc edema because the ischemia is so rampant. There is extensive ischemia of the GCC. That's why this is disc edema extends away from the disc and it's more whitish in appearance, unlike in NAION. Okay, but this disc edema it looks so similar. Okay, so you need to investigate further to find out whether it is ischemic or neuritic condition. Okay. Her left eye fundus was normal. So her fields were okay, but MRI shows a thickened or right optic nerve sheath complex. Okay, the patient was suspected of optic neuritis and she turned out to be MOG positive. All right, so always concentrate on history. The disc, especially in MOG optic neuritis, at times these conditions can give you a differential diagnosis of NIRN. But again, stick on to the history and then MRI will tell you. The next case, a 60-year-old male, he presented with gradual painless loss of vision in the left eye since 3 to 4 months. He is known case of thyroid eye disease and is also diabetic. Okay, left eye, as you'll see, vision is less, RAPD is present, color vision was defective. He had no ophthalmoplegia because of his thyroid eye condition. At this right eye is normal, left eye. How is this disc edema? What do you think could be the cause of disc edema in this patient?
Thyroid optic neuropathy.
Thyroid optic neuropathy. Okay, can this be an ischemic optic neuropathy because he's diabetic also? Will that be a differential diagnosis for you?
Can be.
Can be. Does vision drop is gradual in ischemic optic neuropathy?
It's sudden on.
I mean, the mechanism
Yeah.
of this side optic neuropathy, there is some amount of ischemia, but if it is because of diabetic, he'll have a more dramatic presentation rather than a gradual and painless one. Okay, so you'll see here fields are defect. He has a 3-quadrant defect in the left eye. This is the MRI picture. Can anyone describe the right side? You'll see the extraocular muscles are the thickening is normal. What about the left eye? Can anyone describe this? Rutuja, how is the UM?
Ma'am, on the left eye, the medial rectus and the inferior rectus look thickened as
Compared to the right side.
compared to the right side.
I feel all the extraocular muscles are enlarged. At which orbital level would you assess the thickness of the extraocular muscles? What is normal? Where do you assess?
Mid orbit.
Mid-orbit.
Near
You
the
should,
tendon
that's a dictum.
insertion.
Yeah, you all should always measure the thickness of the extraocular muscles at mid-orbital levels. Okay. So this patient had thickening of the extraocular muscles, so sparing of the tendons. If tendons are involved, which condition is it, Vansh?
Not
Which?
sure, ma'am.
Huh?
Not sure, ma'am.
Not sure. Anybody can help him? Divyansh.
I mean, inflammatory orbital.
Myositis, inflammatory conditions. Okay. So this patient had apical crowding also because of the enlarged EOM. So this patient has a left active thyroid eye disease with dysthyroid optic neuropathy. Okay, I'm not going to management of any of these cases. I'm sticking on to the conditions or causes causing unilateral disc edema. Next, we have 48-year-old female. She presents with gradual pain is defective vision in the left eye since 2 years. Right eye, everything is normal. Left eye vision is defective. RPD is here. Color vision also defective. Okay, now see on her left eye disc shows this kind of disc edema. So what do you think it can be? She's hypertensive. Can this be ischemic optic neuropathy? What is one aspect going against or ischemic?
Gradual pain.
Gradual. Okay, this is almost chronic thing. So again, feels she had a three-quadrant defect, but MRI showed thickening of the optic nerve sheath complex. Okay, so this patient had optic nerve sheath meningioma. All right. So usually on MRI, each structure is based on what signal there. Okay, the signal characteristics is spoken about or described. Okay, in optic nerve sheath meningioma, the optic nerve signal is usually normal. Okay, so what is tram track sign? Since it is meningioma we're talking about.
Ma'am, due to the when we see the section due to the thickening of the optic nerve sheath, we see two lines in a track, like a tram track.
Okay,
That's why it's called as a tram track.
yes, there has to be some deposit there to
Yeah,
your
yes,
tram track.
ma'am.
What is the deposit?
Calcification, ma'am.
It's secondary
Calcification. Good.
calcification of the meningeal sheath.
Okay, any idea what is dural tail sign?
Uh, Ma'am,
That is the cranial meningiomas, wherein at the dural sheath comet tail sign, which we have, wherein like a comet and its tail, we see the
Okay,
trailing.
basically intracranial meningiomas along the border of the convexities. That thing is called dural tail sign. Very good. And Nikhil, you are here, is it? Okay, fair you. Fine. The next case, a 27-year-old female. She presents with subacute vision loss in the left eye since 15 days. Vision, color vision, everything is defective, but she did not have a frank RAPD for this amount of vision and color vision defection. Okay. Yeah. This is her fundus picture in the left eye. Can you describe this fundus photograph?
Ma'am, media is clear.
Okay, let us just confine to the disc and the positive findings. Okay.
And we can't make out the size of the disc because margins are blurred and fairly pale disc.
Pale disc.
There are hemorrhagic spots in the center.
Rituja, would you like to modify what he says?
Ma'am, the disc in the left eye looks elevated with blurred disc margins and obscuration of the blood vessels because of the blurring, and we can see exudates which are there at the
Confined disc. See, Nikhil, you do not call them hemorrhagic spots. They are streak hemorrhages. There is disc edema with streak hemorrhages. And the macula, go on, Rituja. At the macula,
we can see exudates suggestive of a macular star, which is due to the orientation of the nerve fiber layer over there, which is why we have it in that
Okay.
macular star.
fine. At which level are these hard exudates usually settled?
RNFL.
RNFL? Okay, this is for you guys to find out. Okay, what is probable clinical condition she has?
Neuroretinitis is what we says.
Very good. See, because she does not have RAPD, though in spite of defective vision and defective color vision. Okay, so assessment for pupillary examination is very important. Okay, fine. In neuroretinitis, which is first to occur? Nikhil, is a disc edema first to occur or the hard exudates?
Ma'am, disc edema.
Okay, so why does hard exudates come later? Simple.
Stasis.
Why is there hard exudates? Where do the hard exudates come from?
Ma'am, stasis of
Cases.
venous blood.
Divyansh, you guys are going to find out about the pathophysiology.
Inflammation.
No, find out and let me know. Okay, all of us mail me the answers. Okay, what are the other conditions where you can find a macular star, complete or incomplete? What are the conditions?
Syphilis.
No, we're not talking about inflammatory. Syphilis causes neuroretinitis. I'm not asking about the cause. Other clinical conditions where you can have. Okay, hypertensive retinopathy, malignant hypertension, or in papilledema also you can have hard X-rays of the macula. Okay, this patient had non-specific defects or fields in the left eye. She was suspected to have neuroretinitis. All these were the blood tests done. Her neuroimaging was normal, so she was treated for neuroretinitis. Okay. Next, we have 63-year-old male who presented with sudden but painless loss of vision in the left eye since a month. Right eye was normal. Left eye, his vision was no PL. Okay, and this is his fundus photograph. Anybody can describe this fundus appearance?
Left eye, we can see that the disc is disc margins are elevated. The disc borders cannot be made out. There are plenty of cotton wool spots as well as hemorrhages on and around the disc, and in the surrounding retina as well. Kind of probably suggestive of an ischemic CRVO or
Okay, we'll see what this patient had.
the
Okay,
occlusion.
this patient MRI he had thickened left optic nerve, and contrast also showed thickening of the ocular codes also. Okay, what I didn't tell you all was this patient has adenocarcinoma of the stomach with liver mets. Okay, so he had infiltrative optic neuropathy. The mechanism of vision loss you'll need to read up. Okay. Then moving on to next case is a 58-year-old female. She had a painless defective vision in the left eye
Ma'am,
since
ma'am, just one thing. In the previous case, the diminution of vision was gradual or
sudden.
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 Ma'am, infiltrative, we normally have sudden only in presentation.
Again, the mechanism varies. Okay. If the optic nerve substance as such is involved, is usually a gradual drop. But if the infiltration takes place in the vessel, when this vascular occlusion, that is when they present suddenly. So the mechanism vision drop can be multiple. Okay.
Excellent cases, and photos were really nice. I think Pranav had was answering right in between for the previous case.
Yes, ma'am.
Pranav, you told CR Vivo, right?
Yes, ma'am.
How can we CR Vivo present with no PL vision?
No, ma'am. It's unlikely. It's not possible actually.
Yeah, so primarily you should not say it's a CR Vivo. Maybe because of gross disc edema, they can have secondary venous occlusion, but you should think of some other pathology. Okay, go ahead, Vidya. Thank you.
Thank you.
Ma'am, one doubt, ma'am.
Hmm.
In the photo, did we the white spots, were they cotton wool spots or they were metastatic infiltrates, ma'am?
These are cotton spots.
Okay, ma'am.
Okay. Metastasis as such, if such is there, you'll also have it's such an extensive thing. You'll also have vitreous seeds and everything. This you guys, I want you all to know what's the other cause of one peculiar cause of optic disc edema. Here we have 52 female. She presented with defective vision in the left eye. Left eye vision was less. RAPD was present. Color vision was moderately affected. Okay. She also had vitreous cells. This is her disc picture in the left eye. She has a gross disc edema, really angry looking, a lot of hard exudates. Okay. Fields showed peripheral constriction. Okay. Do you all think an optic neuropathy presents with a peripheral constriction? Have you ever thought about the pattern of the visual field being affected in disc pathology and retinal pathology? Yeah, usually enlarged blind spot or central defects are more
Central
common with
defects.
optic neuropathies. Okay, anything retinal cause usually has peripheral constriction, but this condition you see, she had a peripheral constriction in the left eye. Okay, ultrasound showed optic disc elevation, gross elevation with localized little detachment because that edema so much it had to pull along the retina along with it. Okay, MRI was grossly normal, but it was subtle thickening of the chororetinal layer. Means ocular coats were thickened. So the optic nerve signals are normal. Only the ocular coats are thickened. Peripheral constriction, the gross disc edema, and optic nerve head showing enlargement. So what do you think this patient could be having? What I wanted you all to think is, in spite of such a dramatic looking disc, her color vision was fairly good, right? So do you think there's the optic nerve functions are affected
Ma'am,
very much?
vasculitis. I mean, retinal vasculitis because of TB.
Retinal vasculitis fundus, the rest of the fundus appeared okay, isn't it? Except for this. You're not having any other features of
No
vasculitis due to
sheathing,
whatever.
nothing, no cotton wool spots.
So what do you think? Any wild guess? Patient had optic nerve with granuloma. Heard about it? Who's Vidhya gold medaler here?
Ma'am, both.
Who both?
Divyansh and Rutuja both.
Oh my. Okay, I think I'll take them. Anyways, next case. Okay. So here we have a 38-year-old female. She present with headache and also had transient blurring of vision in the left eye. Okay. And she's also on treatment for infertility. Does the history of treatment or infertility doesn't make a difference? Is it important? Why?
Ma'am, patients who will be on oral contraceptive pills, so they are more hypocoagulable normally. There are more risks of thromboembolic phenomena in those patients.
Okay, one is thromboembolic
Yeah.
phenomenon. Other thing is hormonal supplements can do. We'll see what she has. Okay, so her ocular findings, vision, color vision, everything was normal. Fundus, if you see the right eye, there's only minimal blurring of the right eye disc margin supranasally. Left eye, there's early disc edema. Okay, so in setting of a female in the reproductive age group with headache, with TVLs, okay, and on treatment for infertility, what do you think she could be having?
In idiopathic intracranial hypertension in those.
Can it still be this? I mean, it is so much of asymmetry it is there. Can it still be papilledema or IH? It can be. Okay. See, her fields were normal. OCT, the RNFL were fairly okay. GCC was normal. MRI showed widened perioptic CSO space and empty cella. MRV was also normal. Remember, in all patients with papilledema or bilateral disc edema, when suspecting papilledema, do not forget to order MRV. Okay, so this patient, her CSF opening pressure was 35 centimeters of water, and she had asymmetrical papilledema. Okay, next are the few cases what you all should know, definitely know is he was 57 on male. He presented with redness and watering the left eye. Visual acuity was good. There was no RIPD in either eye. Color vision was good. He also had AC and cells in the AC and vitreous. Okay, so this you can see here left eye showed disc edema, and with Predford and Homide, he had resolved. So what disc edema was this? Inflammatory disc
Inflammatory
edema.
disc.
Okay. Next is a 20-year-old male. He had diagnosed secondary glaucoma. He underwent TRAB elsewhere. His IOP was only 2 mm in the left eye. Okay. So if you'll see slit lamp, he had a thin overfiltering cystic bleb, and he also had cross disc edema. Okay. So what is the reason for disc edema in this patient?
Hypotonic
Hypotonus.
disc.
How does the hypotonus globe causes disc edema?
Because of
What is the
the
mechanism behind that?
collapse of the
And
venous
the difference
flow.
between the ICT and the IOP, IOP is usually higher than the ICT. And whenever we have the IOP which falls below the ICT, then we are prone to have disc edema.
That is one reason. There are multiple causes or physiology behind disc edema and hypotonus globus, many.
Okay, ma'am.
Okay. Read up again, mail me the answers. So post flap suturing, there was a gradual reduction in the disc edema. Okay, so this patient had disc edema in a hypotonus globe. Coming to our last case, this is, as you'll see, the 62-year-old male. He's diabetic and hypertensive. Vision is good. There's no RAPD in either eye. Color vision is intact. Can you describe the left eye fundus photograph? Quick, these are positive findings.
The eye is clear. There are multiple hemorrhagic spots along the superior and inferior blood arcade.
Go ahead.
Blood vessels are tortuous. Few cotton wool spots are present
So the
superior.
vessels, your tortuous, what else?
Ma'am, obliterated tortuous vessels.
You want to make sure I-
Dilated tortuous vessels.
Dilated, tortuous, what else?
Few cotton wool spots are there superiorly.
First finish the vessels. What else you see? The dilated tortuous, what else? They're congested.
Yes, ma'am. Congested.
Then disc, how is it?
Ma'am, this margin is blurred. Few hemorrhagic spots in to nasal side of the disc as well.
Disc appears edematous.
Edema.
So what is the reason for disc edema in this patient? What I need to know is disc edema
Yeah,
can
yeah.
occur in the setting of retinal stasis or retinal vascular occlusion. The mechanism, everything, I need you guys to read up. Okay. So what all cases we went through today? for unilateral disc edema?
Ma'am, hypertensive CRVO can cause,
What all cases you see it for
ma'am,
unilateral disc edema?
NAION, GCA, then
GCA? GCA?
GCA we not see, ma'am. NAION, CRVO, then
Simple question. What all cases? I showed you all today. That's all.
NAION, diabetic papillopathy, optic neuritis,
Hmm.
optic nerve sheath meningioma, optic nerve head granuloma, infiltrative optic neuropathy, CRVO, hypertensive retinopathy, inflammatory disc edema, neuroretinitis, dysthyroid optic neuropathy, compressive optic neuropathy, and atypical papilledema.
Atypical papilledema.
Asymmetrical, sorry, asymmetrical.
What is the take-home message from today's class? You guys need to tell me what have you understood.
That we need to add up all what the history is, how is the onset, how is it progressing, what is the visual acuity and presentation. Then we need to look at the disc. We need to differentiate between a true and a false disc first, a false edema first. After that, we need to know the surrounding macula and the vessels. We need to rely on clinically directed imaging, and finally treat the cause.
History taking is going to make a difference. Good history taking, along with a very good clinical examination, is going to tell you what the patient is having. Okay. By the end of the clinical examination, you must have a differential diagnosis or diagnosis also in many clinical scenarios. It is very important because based on this, and based on your judgment, you're going to ask for investigations. We cannot subject the patient to the variety of investigations available. You need to taper it down, okay? And this is important because you need to initiate treatment at the earliest in those conditions where treatment is possible. Okay? Any doubt?
Why are there peripheral field changes in the case of an optic nerve granuloma?
Okay. See, basically, either even in granuloma or in papilledema, which is progressing, it does not start with a central defect. It's not like that because it affects the choroidal vasculature, okay, or the retinal vasculature. Whenever the blood supply to the retina or the choroid is affected, the visual fields are usually from periphery to center. Normally, okay. Vignesh, any doubts you have? For you all to know what is abnormal, you all should know what is normal. Okay. So read about the anatomy, read about the normal variants. Okay, like a few examples what I said, brucines and tilted disc. There are multiple n number of disc anomalies. Go back and read all that. Okay, we'll wind up. Thank you.
Thank you so much, ma'am.
Thank you so much, ma'am.